Can everyone hear me? Okay. All right. Sorry about that. I'm Virginal Owens. Good morning, everybody. Hope you had a good start of your morning. I'll be doing my grand rounds on intraoperative spinal neuromonitoring. Have no disclosures. So this is just a quick overview of what I'll be going through. I'll start with a case introduction. Then I'll get into what neuromonitoring is, talking about the origins, types and thresholds, different uses and checklists that we use here regularly. I'll end with the case wrap up, and then I will end with the conclusion. So this is just a case introduction. So this is an 11-year-old female who was seen in clinic for some time for this scoliotic curve. Over time, she failed bracing and continued to have progressive deformity of her curve. So the ultimate plan was to do a T3 to L3 fusion for this patient and deformity correction. So we'll start with origins of neuromonitoring. So there began a paradigm shift in deformity in the 1960s, starting with aggressive surgical approaches for spinal deformity. Dr. Harrington, who you see on the right there, started correcting deformities with distraction. While this was found to be effective, it started showing an increase in neurologic complications. In 1974, the Scoliosis Research Society looked at 7,800 operations using Harrington instrumentation and found that 87 of them had spinal cord problems, 74 had severe spinal cord lesions, and 50% were complete. There was also found to be an increased risk with aggressive wedge osteotomy. And around this time, the prevalence of neurologic complications was anywhere from 0.3 to 1.4%. In terms of the Stagnara wake-up test, this is the first widely used intraoperative test that started in 1973, and the steps are really simple. You tell anesthesia to reverse the anesthesia that they're using, whether it be IV or gas, and then once the patient is awake enough to follow commands, you tell them to move their extremities. So this was found to be simple and effective. You could figure out gross motor deficits with about 100% accuracy, but the patient must be able to follow commands. Obviously, there are some weaknesses with this that you can think about, is that it's non-specific, so you can't evaluate the nuances of the motor tracks. You can only evaluate gross motor eval. If there was any type of intellectual, developmental, or language barriers, that limited your sensitivity of the test. And if the patient was brought up too much and was too awake, you could have loss of IV access, positioning, intubation due to the patient moving. And there are also some accounts of patients remembering these events after you woke them up. In 1972, Tamaki et al. Looked at spinal cord evoked potentials, and this was found to be easy for surgeon use. It was simple hardware, but the problem with it is that the electrodes that you use actually had to be in the epidural and intrathecal space. So oftentimes you had to take away bone to actually use it. In 1980, Merton and Morton looked at muscle action potentials, and this was really one of the phase changes in neuromonitoring, where they looked at transcranial motor cortex stimulation and found it to be very effective. It didn't work initially because what they found is that general anesthesia, specifically with nitrous oxide and halogenated gas, severely reduced the signal that you could get. But this was resolved with IV anesthesia with fentanyl and propofol by Jelinek et al. Just really quickly, just thinking about some of the etiology of spinal cord injury. This list is by no means exhaustive, but you can have trauma dealing with pedicle screw insertion, dealing with how you use your knife, or just with blunt force with any instrument. Ischemia due to hypertension, volume depletion, and anemia, and also manipulation, just positioning the patient before surgery, and also intraoperatively doing things such as distraction, compression, or translation. So I'll go through these three main types of neuromonitoring that you see most commonly in spinal surgery. The first is somatosensory evoked potentials, the second is motor evoked potentials, and the third is electromyography. And then just thinking about some terminology, there are three things to kind of think about as we continue. Amplitude, which kind of deals with the wave you see on the right, the size of the response that you get. And that's usually considered to be the most important. Latency is the time that you get a response from when you start the response. So you can have a latent period before you actually get a response on the recording. And morphology deals with the shape, which you can see with all the colors coordinated there. So the first type is SSEP, or somatosensory evoked potentials. And the step is to first stimulate a peripheral nerve. Most commonly, the nerves that are stimulated is the ulnar nerve or the posterior tibial nerve. And then you record transcranially. So strengths with this is that it's very easy to implement and it's readily available. It's the neuromonitoring modality that has been used the most for the longest. It's a good basic indicator of cord function, and it also helps with positional changes. So if the patient moves, or if you distract in a certain way, or if the leg falls off the table, it's good for kind of monitoring those changes. The limitations is that it delays, there's a delay in response time. So there's actually an averaging system in the machine where you get the signals and it has to average out the response. So you can have an injury to the cord, and you sometimes can have a delay in the response time up to 20 minutes. So you can have an irreversible injury before you even know it. It gives you obviously no detail on motor tracks, since the sensory is all in the posterior part of the cord and motor is more anterior. And it's also sensitive to gas, anesthesia gas, and also the machine noise in the room can also affect the signal. MEP is the second type I'll talk about, of motor evoked potential, and it's the opposite way. So you stimulate transcranially, and then you record distally in the peripheral nerves or the spinal cord. So you can record using D waves. This is not really used too commonly. It's really not used here from what I know. The most ideal is using muscle action potentials or myogenic potentials. Optimal sites include the muscles that I kind of have listed here: quad, tibet, gastroc, trap, delt, bis, tris. And you can adjust kind of where you monitor depending on where the level of the surgery is. So the strengths is that obviously you can track motors, and there's also less of a delay of injury awareness. So oftentimes the motor evoked potentials are used after major parts of a case. If you are doing a decompression, or if you're inserting pedicle screws, or if you're doing a manipulation for deformity correction, oftentimes you will do these to see if there was a change before and after those changes when you did it intraoperatively. The limitations obviously is not continuous, so you actually have to send off a signal to get a response. It requires 4 out of 4 twitches, which basically means that the patient can't be paralyzed, and is very, very sensitive to anesthesia, particularly gas. And that's one of the things I talked about earlier. So IV anesthesia is usually preferred, but even IV anesthesia can severely decrease your motor responses if the patient has too much anesthesia on board. Other things include tongue lacerations, seizures, and it's not compatible usually with kids under 6 years old, and that's due to the fact that their motor tracks are not fully developed yet. The third type is EMG, and there's 2 types that are usually done. First is electrical, and that is also known as triggered. This is during static phases of surgery. So you usually see this during the times where you are beginning to place in pedicle screws and you're evaluating for whether you have a breach or not. This is an example on the right, kind of showing the probe, identifying if you have a medial pedicle wall breach. And you also have mechanical, which is free run, and this is during dynamic phases of surgery. So you can use it when you are doing a manipulation, placing a rod and trying to correct the deformity. So it can provide a real-time recording of the peripheral musculature. So the strengths is that it can easily be used with MEP or motor evoked potentials. The reason being that the leads that you use for motor evoked are similar or basically the same. So you can use EMG and the MEP very easily together. It has almost 100% sensitivity for medial wall breach, and it's useful also in minimally invasive surgeries. So the weaknesses is that it's less sensitive and reliable for thoracic levels of pedicle screw placement. The idea being that the signal that you get from a muscle, so if you did it from the extremities, is much more consistent than if you try to get it from the thoracic musculature, which has much more overlap. It doesn't actually assess neurologic injury, so it can tell you if you have a breach or not, but it doesn't actually tell you if you actually did damage to the cord. You can't use muscle relaxants. If you have chronic compression, this can actually give you a higher threshold. So the idea being that you're stimulating a nerve, but if the chronic compression has caused the signal overall in the nerve to be decreased, it'll take more of a signal, which can give you a false reading. And also osteoporotic bone can affect your reading as well. This is just a quick summary. So SSEP is a good basic indicator. It's continuous, easy to use, but it has a delay and it doesn't give you any motor track. MEP gives you motor track, smaller delay in injury detection, very anesthesia sensitive, not continuous. EMG, medial pedicle wall breach is almost 100%. It's great with minimally invasive surgeries, and you can use it easily with MEP. Doesn't give you any actual idea on neurologic injury, and the thoracic level is less sensitive. But of note, all three of these can be affected by the stuff I listed kind of at the bottom: blood pressure, anesthesia, temperature, positioning, lead placement, and patient history. All of these can affect these values in different ways to varying degrees. So it's important to consider all of these, which we'll talk about later too. In terms of thresholds, it really depends on who you talk to, what paper you read, where you are, what institution. But generally for SSEP, if you have a greater than 50% amplitude loss or a greater than 10% latency, that would trigger an alert. For MEP, somewhere between 50 to 80% decrease in amplitude would trigger an alert. Some people actually do all or none response. And for EMG, there hasn't been any specific parameters that have been defined, but usually if you ask somebody, it's usually around less than 8 to 12 milliamps when you are doing a trigger response that could be indicative of a breach. So we'll go into some uses and we'll talk about pediatric scoliosis first. So for pediatric scoliosis, neuromonitoring is considered the standard of care. There's been multiple studies that show that it helps to mitigate the risk of permanent injury and adverse neurological outcomes. They recommend that you use combined neuromonitoring modalities. So pretty much everyone here does SSEP and MEP. In terms of EMG, this is not considered standard of care at this time. And the reason is multifaceted, is that it's less sensitive in the thoracic spine, which you need pedicle screws in that area, usually for scoliosis patients. There's no established thresholds. So sometimes certain surgeons use it, but it's not on a consistent basis. In terms of the cervical spine, May et al. Looked at some general indications. Preoperative myelopathy carries a strong risk of potential intraoperative and postoperative neurologic compromise. So it's very good to use neuromonitoring in that regard. If you increase the extent of the surgery, this is usually a good idea to use neuromonitoring, upper cervical surgery, posterior instrumentation, and also any type of neck manipulation. It can also help recognize C5 nerve root palsy, which is one of the most common complications with posterior cervical surgeries, acutely but not delayed. In terms of anterior cervical, specifically things like ACDFs, this is controversial in the use, and the reason is kind of multifaceted. It kind of deals with cost, deals with efficiency. It also deals with when you are thinking about the type of surgery. So if you're looking at a cervical radiculopathy patient versus a cervical myelopathy patient, some people will argue that the radiculopathy patients don't really need this type of neuromonitoring, given that the level of neurologic compromise is very low. In terms of thoracic, overall, it's widely accepted for multiple pathologies. Lung et al. In 2015 looked at the unique aspect of the fact that anterior segmental vessel ligation can severely affect the cord. If you ligate a potential vessel that can carry a wide area of territory, MEP can help to identify the ischemia critical levels prior to any type of ligation. And EMG use is also increasing over time as well. In terms of lumbar use, this is also increasing. Many surgeons are starting to use it for pedicle screw fixation. Many surgeons are also using it for the T-lifts or transforaminal lumbar interbody fusions. Also, as the level of complexity of procedures is increasing over time, the neuromonitoring is also increasing as well. It has a controversial use with simpler procedures, for example, one-level lumbar fusions. Some surgeons argue that the cost and the efficiency and the low level of neurologic injury doesn't really justify you using neuromonitoring. So sometimes it depends on who you ask. Overall, there's increasing use of EMG. Gunnarsson et al. Looked at EMG activation in 77.5% of a series of complex thoracolumbar cases. And after the activation was addressed, deterioration was only found at 6.6%. So it can really help to avoid permanent injury. In terms of tumor, it is well supported to use in literature. Reese et al. Looked at a 2019 meta-analysis and saw that combined use of SSEP and MEP multimodal neuromonitoring has the highest sensitivity and specificity. And obviously it makes sense that SSEP is effective for evaluating tumors in the posterior part of the cord, and MEP is good for the anterior part of the cord. So this is a neuromonitoring event checklist that the residents here for ortho use a lot, particularly with the PEDS team doing scoliosis cases. You can find this in OR 11. I'll just talk quickly about how it was developed. So Vitale et al. In 2014 did a literature review of risk factors and recommendations for intraoperative neuromonitoring changes. He worked with a total of 21 spine surgeons, 1 neurologist. They did a total of 4 surveys for this. There was a group process and ultimately a Delphi process, which you can see an example of here on the right, with 3 face-to-face meetings, just kind of compiling this entire checklist. Of note, they didn't want to make an algorithm. They wanted to make a checklist that could easily be seen, easily identified and used when you have these kind of high stakes and high pressure situations. So here's the checklist. It has 5 sections. I'll just quickly kind of go through each of the 5 sections. So the first part is gain control of the room. So when you have a neuromonitoring alert, it's important to stop the case and announce to the room that there's a problem. You want to stop any stimuli, people talking, music. And if your experienced team is not in there, an experienced anesthesiologist, an experienced neuromonitoring person, you want to get them in the room. And you also want to think about if you need any intraoperative or perioperative imaging. In terms of anesthetics, you want to optimize the mean arterial pressure. This depends on who you ask, but generally it's considered you want to have a MAP greater than 80. You want to optimize their hematocrit, give them blood, use self-saver, whatever you need to do. Make sure that anesthesia is kind of optimizing their blood pH and CO2 and making sure they're good from a metabolic and respiratory standpoint. Make sure that they're normal thermic. And then you also want to think about a potential wake-up test as the patient's neurologic compromise does not resolve. From a technical aspect, you want to think about the anesthetic agents that are being used. If there is gas being used and there's a motor problem, it's probably important to kind of think about if that is affecting the monitoring. You want to check the electrodes and the connections. So if you fire off a motor evoked potential and the patient jumps, it's not uncommon that a lead can pop out when they jump. So it's something else to think about. You also want to think about the neck and limb positioning. Sometimes the leg can fall off the table, arm can fall off the table. So it's important to think about that too. From a surgical standpoint, this kind of makes sense. If you put traction and something happened, remove the traction. If you place rods and then something happened, remove the rods. And you also want to evaluate for your spinal cord compression if you did any osteotomies or laminotomies, and evaluate if there's compression on a nerve or if there is a bony fragment or cement or anything. And then you also want to think about if you should bring in X-ray or O-arm. And then other considerations is, like I said, the wake-up test. Consulting a colleague is also very helpful to make sure that you can bounce ideas with somebody and make sure you're doing the right thing. And then one of the hardest things to think about is, should you continue the surgical procedure or should you stage it? Is it safe to stop? Sometimes when you destabilize a spine and you have to put in stuff to stabilize it and neurologic complications happen, I feel like that's one of the hardest things to think about is, how far do we go here and is it safe for the patient? So just thinking about this patient, going back to our 11-year-old, she ultimately went for her scoliosis surgery from T3 to L3. Multimodal neuromonitoring was used, SSEP and MEP. Pedicle screws were placed without incident. As the right rod was placed in, the patient then lost motors on the right side, on the right leg. So similar to what I talked about in the checklist, many of those things were done. It was announced in the room. People stopped talking, music was turned off, temperature was evaluated, vitals were evaluated, hemoglobin was looked at, cell saver was given, the rod was taken out, the sites of the pedicle screws were evaluated. Ultimately, the patient was found to be stable, the leads were in the right place. They talked to anesthesia, the anesthetics on board seemed appropriate for the the monitoring incident. Ultimately, the patient got the rods placed back in and proceeded without incident. Patient woke up and a full neuro exam was done. Patient had no motor deficits. So in conclusion, spinal intraoperative neuromonitoring is a reliable and effective means of detecting impending nerve injury. SSEP is the most available, easiest to use, but MEP is more sensitive for impending neuro deficits because it's more immediate. EMG can help with pedicle screw breach and dynamic phases. Its use in situations is still controversial, and this is a developing topic, secondary to cost, efficiency, certain cervical and lumbar surgeries, but it's standard of care in others, so you will often see it in pediatric scoliosis, tumor cases, thoracic cases. One of the biggest things I think for kind of residents to think about in the future is that it's important to be prepared when an issue arises. So it's important to have a checklist or some type of algorithm or something that you can use when you have these problems, which inevitably will come. It's important to have the right team around you, having a good system, and it's important to try to keep the room as calm as possible so that you can figure out the next steps. I want to thank Dr. Chapman, Pulaski, Scannell, Pat, Brighton, Quan, and Kevin McCord, who was one of the awesome neuromonitoring people here, for helping me. Some sources, and that's people there. And thank you.
Great presentation. I have a general question for you. Obviously, where this is a standard of care, it's not really a question. We just need to do it. But for some of the more fringe indications, it's probably important to know what the cost of this is. Do you have any idea for the SSEP what the cost is per case? Add that to the mix.
Yeah, I don't know the cost between the individual ones, but from what I've heard, is anywhere from $10,000 to $15,000 to have the neuromonitoring team in the room and actually doing it. So that's actually one of the considerations that a lot of people think about, is that for this 45-minute one-level ACDF, do I need this $15,000 cost that either the patient or the hospital would incur? The time that it takes to set it up, is it worth actually doing that? So that's one of the things that people are thinking about for sure.
Yeah, I think that's an excellent point to tag on to. And if you look at every single one of those indications, that's really the crux of when to use it, is when is it the correct cost benefit analysis to, benefit your patient without some undue, we focus on bone grafts and we try and save a couple dollars here and a couple dollars there. You want to talk about taking a chunk out of your surgical, costs, $10,000 to $15,000 taken off the total cost. That's a big nugget. Yeah. I will just make a comment about tumor. I do think that it is very effective, and I think that's what that article showed. The issue is that the most common tumor operation we do is going to be metastatic disease causing neurologic compression with acute or impending neurologic compromise. Most of the folks I know, and I would say I subscribe to this too, do not use any neuromonitoring for those cases. The patient already has a deficit and we're working quickly to resolve it. It's not like we're going to stop taking tumor out. I guess in theory, the only thing you could change is if you did a big deformity correction. So I think if you had significant kyphosis at multiple levels, or you could consider that. The only time I typically use it is if I'm doing an on-block resection where I'm going to provide 100% destabilization to the spine. And I want to make sure that I don't lose control of the spine, over-distract, under-distract, because then I could do something different by changing that. But generally for metastatic disease, I don't tend to use it for that reason.
Gotcha.
Great talk, though.
And that's one of the things I read about too, is that it's effective for monitoring, but one of the things they found in the meta-analysis is that surgeons can almost take out less tumor because of the neuromonitoring deficits that they could kind of see. So it's kind of going to your point of, they already have a deficit. It's probably more important to try to get as much of it out as possible.
Thank you for the talk. The information is really helpful, and just across subspecialty issues. We've had a few cases on the hips, congenital hip side, where we've tried to utilize this for lengthening or limits on lengthening of a lower extremity, because our current technology, if you'll call it, is really medieval. We use, you know, estimations and guesses, and we base it on some studies that are compiled over about 15 years of neurologic injury. So we really don't have a technical science down to how we limit lengthening of a leg on the hip side when we're utilizing hip replacement or revision hip replacement. So one of my questions, some of our experience with this, which is limited, is I guess my question to you is, and I'm not sure I should call it a false positive, what is the frequency of an MEP signal abnormality that doesn't go away, but leads to no motor deficit or no neurologic deficit? Meaning that you have the abnormality in the operating room, you prevent any further distracting, or you take away your lengthening, you change all the mechanical things you can. And at the end of the case, and after, you know, reversal of anesthesia, patient does not have a neurologic deficit.
You want the incidence of effect on the patient or the doctor? Because I can tell you the effect on the doctor of that is extremely high, causes arrhythmias, blood pressure elevation.
Yeah.
Is there any literature on that?
So that's a good question. And I was actually looking at kind of sensitivities and specificities and false positives, blah, blah, blah. And the thing I kind of came to the conclusion of is, yes, both of them are good together, but it really depends on who you ask. And it also, so it's kind of multifaceted. It depends on kind of where you're doing the surgery, depends on the patient's history. It depends on the team. It depends on the surgeon's comfortability with neuromonitoring. It depends on the neuromonitor, it depends on the anesthesia team. All of these can kind of affect the readings. So sometimes you can get these readings and you can, depending on who's in the room, you know, one surgeon versus another could say, oh, that's nothing. And another surgeon could kind of freak out. So.
What from JPS kind of like noted about an 8% false positive rate where there's no deficits.
Yeah, it may not be a false positive, might not be a good terminology.
Sure,
sure. You might have neurologic injury.
Right, but it's about 3 to 8% is what they put. You know, I think anyone's done, whether Deformity Spinal has probably had those cases where they're like, that doesn't make sense, where, you know, everything's in, correction's done, and then 5 months later, they're saying we've gotten 50% decrease in amplitudes, you know, you can decide whether to do a wake up test and so forth. But, you know, I think to me that's usually just like
wake up test.
Now, what happens during the correcting is fine. But, you know, again, as far as out there, it's not 3%. The other thing, Bert, is that great talk, by the way. It's very regional, depending on like where you go as far as like what the standard of care is. So if you go to New York, you go to Philadelphia, and they'll monitor anything that is hardware in it, ACS, one level TLIFs. You come to other regions, you know, such as Charlotte, and that's not the standard of care. So I think it changes based on.
Thanks for everybody's comments. Dr. Owens, great talk. Appreciate it. And we're going to move on to talk to those of you who tuned in late. CME color for today is gold.